reporting to adverse drug reactions. Madam Rajalaxmi Mishra will be highlighting on all those aspects. So because she is new to us, she is not new to you but new to us, I would like to introduce her to our medical personnel. That she is holding the post of Principal of College of Nursing of Berhampur since 2013. She is a graduate of the same college in 1991 and has completed her post-graduation from RAK College of Nursing, New Delhi in 2002 and now pursuing PhD under Berhampur University. She has been enrolled as the NQAS assessor under the MHSRC of Ministry of Health and Family Welfare, Government of India. She is also a syndicate member to the Berhampur University and member of Departmental Research Committee of Department Berhampur University. She is also the member of Board of Studies to various other universities like KIT and Utkal and so on. So welcome, madam, to our.
Good afternoon, everyone. Esteemed professors of different departments, faculty of this medical college and nursing college and school of nursing, students of medical college and nursing college. I am having a bad throat. In spite of that, I'll give justice to my topic, whichever assigned to me. I thank first of all to Jayanti Madam, Professor HOD of Pharmacology and the organizing team for giving me this opportunity to stand in this platform to share my views. Mostly, I thank to all the organizing members giving me this opportunity. I am truly honored to stand over this platform and share my experience. I was just thinking, sitting in the audience, the two speakers, what they highlighted, and sitting among the galaxy of intelligence and of medicine, what else speak? But still, there are some points for me to share. So, the topic which is given to me, that is role of nurses as stakeholders in adverse drug reaction reporting. So, as Kiran sir started with this paper cuttings, I just highlighted some of the facts which comes with adverse drug reaction reportings. These newspapers say the doctors are not in safe position, even they have done their surgery best, even they have done their prescribed medicine best, they are not in safe position because their team is not good. So, one doctor's success depends on the team, what he or she has. So, who are in the team? Who are all other stakeholders which the whole recovery of the patients depends on. So, as Madam said very rightly and Kiran sir said, it is not only the doctors, they are stakeholders for ADR reporting. The pharmacist, the nurses, the patient himself, or the manufacturing company, all they are stakeholders for ADR reporting. So, as Kiran sir highlighted many of the things, clinical, what are the ADR, flaws occurring related to ADR in the clinical area. I will just start with one study which is taken in India. This study was conducted by Rahul Sharma in Jaipur, Rajasthan, including private and government hospitals. He included all the participants from different categories, doctors more than 300, the nurses more than 300, patients more than 300, and 37 pharmacists. All the stakeholders, where they stand. And if you look at this case study, this research study, this is a mirror for us. I don't know whether the departmental students of pharmacology, they have taken up such studies here in this medical college, because this is one of the apex medical college catering to the people of southern Orissa and also to the other states, some population of Andhras also. So this study gives us just like a mirror to us. If not, more or less findings you will get similar in our setting if you conduct such type of study. This report study finding says doctors' awareness and practice related to that. 50% doctors perceive that adverse drug reaction reporting creates an additional workload to them. So if you think that, then who is going to report this ADR? So we all, stakeholders are accountable for that. Then, but 99% doctors felt it as their part of duty, and reporting is important to get aware about drug safety. Even we work together as a team, the patient safety is our prime importance, prime motto. 66% doctors disagree or not convinced with the statement that adverse drug reaction which causes persistent disability should be reported. So it should not be like that. It was found that 57% doctors encountered with ADR in the last 1 year, and 45% only reported ADR in their record book or file. Even if 79% doctors they are claiming to report ADR regularly, and 100% doctors claiming to advise patients for possible drug and drug-food interaction in their daily routine. But 93% said neither they had undergone any training related to ADR reporting. 70% said nor they have got ADR reporting form available in their organization. So where we stand, is just analyze it. Then come to the nurses awareness and practice part. 100% nurses have general assumption that ADR reporting is part of the duty of health professionals. That means the doctors are accountable. They are not. 100% agreed it is required essentially to know about the safety of medicine, and 99% said this is important in the healthcare system to report ADR. Majority of the sample, 73% disagree upon the statement that one report make no difference. 76% agree upon the efficiency of ADR reporting by designated person in their organization. So everyone thinks that there is a designated person who will report this ADR. This is not my part of job. 88% they are unaware about whom ADR to be reported. As Madam said very rightly, today only she highlighted to whom will report, how the reporting goes to the global ADR center. Then 49% agrees upon the term that only ADR which causes persistent disability should be reported. It was found that only 34% nurses had encountered patients with ADR in their clinical practice in last 1 year, and 39% said they are less in practice recording ADR. So next comes to the pharmacist awareness and practice. 100% agree upon the term that medication safety is important, and 93% agreed it is needed in healthcare system, but 94% said there is a need to be sure. Before reporting you need to ensure what parents have said, that this reaction is due to drug, not for other reason or any underlying clinical pathology. So they to be sure that ADR is related to the drug before reporting. 35% sample is disagree to the statement that only ADR causing persistent disability should be reported. About 33%, 1/3 sample agreed that it is additional workload by ADR reporting. 70% believe that the designated person for reporting ADR working efficiently, and majority, that is 63% on or about, to whom ADR should be reported. There is no system at all. So they had seen 39% patients with ADR in last 1 year and very less recurring, that is only 13%, although they are majorly, majority 63% reporting ADR. They 63% believe that the ADR should be reported and advise the patient about drug and drug food interaction. Then comes to the patient awareness and practice. What system we have related to patient teaching and sharing the information to the patient. So 52% are not known to the term ADR. But a common alternative term, if you tell to them, then that is known to 94% patients. Majority agreed on ADR to be reported only on doctor prescribed medicine, while maximum, that is 60%, showed they disagree upon the term of not reporting any ADR related to non-prescribed medicine. So both prescribed and non-prescribed medicine, what are their views? There is a low awareness, that is 62% among patients, for reporting only ADR which causes persistent disability should be reported. Majority of the sample, that is 61%, is disagree upon the term that one report of ADR make no difference, and 76% also disagree upon reporting is not useful for the patient. It was found that only 15% of the sample population had undergone any ADR in past, 1 year, he has seen, while only 5% have been hospitalized for ADR. We just saw in the different slides of our speakers, they told only 5 to 10% ADR is reported every year. Nearly 26% sample had been interacting with health professionals for possible ADR, while only 24% of the sample are aware that the health professionals are recording ADR in their clinical report. So that is they are not their accountability. They are not need to report. So this is what the patient knowledge. So this study gives us a mirror where we stand. If we conduct a study here, I think more or less findings will get similar to this study. So I'm not going through details of it, as Sir said, like diluents are not given, reconstitution is done for the medication very early, before the administration, a long interval, it should not be done. This is all unethical practice. Who is responsible for that? So, which patients are most risk for medication error? The patients who are in multiple medication, as I said, polypharmacy. So, the patient who is taking more than 5 drugs, we used to call that patients with another condition, like in case of renal impairment, pregnancy, patient who cannot communicate well, so she can't or he can't share you the drug reaction. Patients who are more than one doctor, they visit to many doctors. Patients who don't take an active role in their own medication use, somebody else is giving. Children and babies, where those calculation is highly required. So I am not going to high alert medicines and high risk medicines are already highlighted those things. And those narcotics drugs, opioids drugs, these are in standards, they should be kept in double lock system. So whether we are following that or not, that is also important. So coming to the hospital administrator's role, as Sir is involved in the administration, I think this can be taken up as a suggestion. I have done so many areas for in-cost assessment. So I have seen some hospitals in Kerala, what they are, how their formulary pharmacy looks and how they arrange. As I said, you minimize and reduce the lesser drugs, that is look alike, sound alike, and all the lesser drugs should be kept in separate containers. All the containers, the administrator need to provide the containers transparent one, so that should be level. The expiry date, manufacturing date should be mentioned, and all the drugs which are near expiry before 3 months also, that should be discarded. That should be kept in separate containers. So all these containers, that should be provided by the administrator only. So this is what the administrator has to have a organizational culture, as Jayanti madam said. We need to inculcate an organizational culture, how they need to report ADR. Everybody has to report. It is not the work of only PG students. It is not only the work of doctors. It is everybody who comes in the adverse drug action situation. They all have to report in the prescribed format as soon. So, what is the hospital administrator's role? There must be a standard operating procedure for disposal of discarded and expired drugs as per BMW rule, that is developed in 2016. So then adverse drug reaction surveillance should be done and strengthened, implemented across all public and private healthcare facilities. It is not only the medical college, all the nursing homes, everyone who is rendering service to the people, all the hospitals, they should come under the scanner of that. Then with close coordination between state health departments, pharmacovigilance agencies, professional associations, drug manufacturers and national vertical programs. There must be an established procedure for ADR reporting, as Madam said. It is not, if you give only the form to them, nobody is going to report it. So that should be inculcated in the practice. Everyone should have that culture to write immediately to the AMC. Then establish procedure for ADR reporting. Importance of CNE. We have seen so many structures, buildings that comes out with seminar halls for doctors, but there is no space for the nurses and pharmacists. They need to be strengthened with their knowledge. They need to be updated with their knowledge every time with the CNE. There must be a continuous nursing education department or continuous medical education department in the hospital site itself for on-the-job training. The nurses, doctors and pharmacists, they need to be trained. Unless until that, we are not going to achieve any quality care for the patient. Then there must be established protocol for medication safety. It is not the doctor's work only to prescribe the medication. It is the nurses who monitors, it is the pharmacist who dispense the medicine. They are equally responsible for rendering quality care. So that should be there. There must be an established policy for verbal order. How will you enter the verbal orders, or how they will document the things. That is very important. Documentation is very important part, which is not taught by Kiran sir. All of the things he taught very nicely. So that is very important, how the verbal order should be entered. That policy must be there in the medical college. Then reduce LASA on your formulary, as sir said, I need not to highlight those things. Eliminate or reduce or minimize the LASA drugs. Ensure to follow standard treatment guideline. That is very important. All the doctors need to be, need to practice this standard treatment guideline. Then conduct prescription audit regularly. As I said, abbreviations. Sometimes the doctors, they write their own invention, new abbreviations. We the evaluators know. The students, many a times in examination paper, they write their own abbreviations to the statements. So sometimes the doctors commit those things in the prescription also. So the new inventions which are not standard abbreviations, that can be misinterpreted by the nurses, that can be misinterpreted by the pharmacists while dispensing medicine. So that is main thing. The prescription audit should be done regularly. How far we are doing that? Develop a system of using evidence-based practice on complementary therapy. We have a big medical college here. We don't have a committee, evidence, how the evidence practice or researches. All the researches are the asset of this medical college. Whoever does researches on their own patient. So all the research, they need to have a copyright system, and that should be disseminated, and those things need to be taken into the practice. if it is done rigorously and proper, honestly and ethically. Then strengthen the research work and a strong research committee for these all ADRs and all. And as I said, the copyright system you need to have in your medical college. This is one example. I have gone to Kerala. This is only the primary healthcare center, and you see the pharmacy, how well organized it is. And the medications, what is available in the hospital, they have disseminated in the lobby area of the patient. So just sharing the information, what drugs are available. They need not to go to outside for procuring those medicines. So preventing ADRs, as I said, patient counseling, teaching is very important. Better communication at the level of patient understanding we have to do. Then consider all the risk factors for ADRs that has to be, as I said, you have to communicate to the side effects. Then as the red highlighted, 70% ADRs are potentially available if we will make our practice organized. If we will make our practice ethically will practice, then I think 70% ADRs we can avoid. So as I said, medication safety, prescribing is the part of doctors, administering is the part of administering, and monitoring is both the part of nurses. I'm not going to this. So one thing, there are 10 rights that nurses should not forget while being administering the drugs. All the 10 rights related to patient, related to healthcare providers, and related to drug, they have to remain. Medication error, as I said, sometimes with the abbreviation, some pitfalls we find, like HCT 250 mg intended for drug hydrocortisone, but it dispensed hydrochlorothiazide. As I said, so I just took an example. So how the verbal and phone order should be documented. So usually avoid the verbal orders, but enunciate slowly and distinctly. State the number like pilots 1, 5, like that in verbal order they need to say milligram or 15 milligram. So one order for NPH insulin 60 units can easily sound like NPH insulin 60 units. So that should be given pilot words like 60, like that they have to give verbal order. Then spell out difficult drug names to the person who is taking the verbal order. These things should come in the policy of how to document the verbal orders if the doctor is outside the hospital. Then specify the concentration instead of giving the dose in number, teaspoonful, tablets, ampoules or vials. Then read back the complete order or test result and see that all the documents, there should be a double check system. As Sir said very rightly, 2 sisters at 8 p.m. if they are administering injection, 2 persons have checked and signed. So there must be double check system. So this solution are identify all high alert drugs, as Sir said. I am not going to highlight those things. Double verification. So this is for the tagging and labeling. Then accuracy of medication management, prescription orders not clearly written, no prescribed format for writing the orders, records not kept for medication management. So we don't have a database also, how many cases, how many ADRs we are finding, because we have not developed a culture, conducive environment, how the employees or the subordinate staffs, they will report the ADRs. So I am not going to all the other things since I have discussed many of these issues. So triaging, as I said in the Kerala, even in the lobby area you will see all the triaging in every department, it should be there. So triaging of minor, moderate and severe or lethal drug reactions, that should be done. So Madam said already where to report, what to report, and how the reporting is done from starting from the occurrence, site of the occurrence to till the global level. Then mandatory field for suspected ADR reporting form. This should be there in the reporting form. Patient initial, age at onset of reaction terms, date of onset of reaction, suspected medication, and reporter information. So, what are the steps for preventing medication error again? Prepare the medication for only one patient at a time. Follow 10 rights. Read labels at least 3 times. Use at least 2 patient identifiers that the name of the patient is that and particular the drug is meant for that patient. Don't allow any other activity to interrupt your administration of medication. Double check all calculations. Don't interpret illegible handwriting. Clarify with your prescriber. Question unusually large or small doses because you can also identify if it is underdose or overdose. Document all medications as soon as they are given. When you have made an error, reflect on what went wrong. Ask how could you have prevented the error. Evaluate the situation. It should be a system, a culture that one should report to the colleague that I have done this mistake or that error and immediately it should be reported. Evaluate the situation in which a medication or error occurred. Ensure you are well rested when you are caring for the patient. Don't take shortcuts. Follow protocols because you are handling the living things. So to conclude, we must always remember that there are no biologically safe drugs. There are only safe physicians, nurses and pharmacists who can make difference doing no harm to the patient. Thank you.
Thank you, madam, for almost summarizing all the speakers' topics. Very nicely highlighting the importance of the nursing personnel in ADR reporting. We'll be conducting more and more awareness programs as told by you. There should be a continuum of education for nurses also, and you need an area that will be taken care of, and we'll be conducting more and more sessions on these area reporting. We'll be doing hands-on training, in fact, how to fill the area reporting form and all those. Thank you, madam, once again for sparing your time. It was very nice of you. Now we will go and pick the token of appreciation part. I would request our professor and HOD madam to come on the stage, and Rajalaxmi madam and sir also.